Welcome to part 2 of the Who's Who in Glaucoma series. We are so excited to continue this journey with Dr. John Berdahl, who everybody knows and loves and has requested multiple times from the Woo U survey. So we're so excited to have him. My name is Dr. Stephanie Woo. I am your host for the evening, and I am the founder of Woo University. It's now my pleasure to introduce tonight's speaker. Dr. John Berdahl is a board-certified ophthalmologist at Vance Thompson Vision. He completed medical school at Mayo Medical School and his residency at Duke University, followed by his fellowship at Minnesota Eye Consultants. He's widely regarded as one of the leading international cataract surgeons. He's one of very few surgeons in the United States who's also fellowship trained in cornea, glaucoma, and refractive surgery. He has performed more than 35,000 eye surgeries around the world. He's also been involved in numerous FDA-monitored clinical trials on some of the most exciting technologies in ophthalmology. He is the founder of Equinox, which I'm very excited about, which is developing the first non-surgical, non-pharmacologic way to lower eye pressure for glaucoma treatment. And in effort to improve access to care, he co-founded Expert Opinion MD, which gives online options to patients from top doctors around the world. Although Dr. Berdahl has many accomplishments, his primary driver is the trust that people place in him. And this is an actual review from one of Dr. Berdahl's patients. As an eye surgeon, I made the decision to travel from Utah to Sioux Falls to have Dr. John Berdahl perform my surgery. I was able to experience their famous team approach to patient service and care. Amazing, such nice and caring people. Thank you. So Dr. Berdahl, welcome to Woo University.
Thank you so much for having me, Stephanie. It's a pleasure to be here tonight. And, you know, for those of you that I bet it's pretty obvious, I went to church tonight for Ash Wednesday, so that's up there on my forehead, but I'm excited to dive in. Here's my financial disclosures. I consult for a lot of glaucoma companies, including one that we'll talk a little bit with, Equinox, which is the one I founded as a non-invasive way to treat glaucoma. So we're going to be talking about innovation in ophthalmology and unmet needs. And I just want to start there for a moment on what really is an unmet need. And I think that an unmet need in I'm a former math teacher. So in my mind, it's the area underneath the curve. What does that mean? Well, if it's something like cataract surgery where we have good solutions, but we can make an incremental change that makes cataract surgery bigger and better, that's a meaningful improvement. Or we can take something like what I'm going to talk about, and that's advanced glaucoma or glaucoma where people advance at low and normal eye pressures that don't have good solutions. And that's also an unmet need. So what we're really going to be talking about today are the unmet needs in glaucoma. What is glaucoma? And so what? Why does that matter? Why should you spend an hour with us on Ash Wednesday tonight? And my goal is to simply make this hour well worth your time. So we got real problems in glaucoma. The first problem is, what is glaucoma? And the definition is, we don't know. Now, the textbook definition is an optic neuropathy with characteristic visual field changes and characteristic optic nerve cupping. But I haven't heard a less satisfying definition to a disease, and I don't walk away from that knowing anything more than really it's an optic neuropathy. But what we do know that it is an optic neuropathy, there is cupping and there's visual field loss. What causes that cupping and visual field loss? Well, we don't know. But at least we do know that IOP matters. Why does IOP matter in the first place? Guess what? We don't really know why IOP matters. But what we do know is IOP is the pressure inside the eye. But that's not even actually true either. It's the fluid pressure in the eye relative to atmospheric pressure. And before I lose you there, I want to tell you why this is important. Because we've always thought about glaucoma as a pressure inside the eye disease. But the absolute pressure inside your eye changes all the time. It changes as a weather front comes through. And so what's critical is the pressure in our eye, the pressure in our blood vessels, the pressure in our heart, our cerebral spinal fluid pressure, all relative to the atmospheric pressure. And to understand this pressure, we must understand the proper reference point, which is the atmosphere. And this becomes critically important as we're talking about what we're going to talk about in a little bit, which is goggles. So let's go way back for a second and say, when Goldman applanation was invented, what was it intended to replicate? It was intended to replicate a manometric intraocular pressure. So it was validated against sticking a needle in the eye and seeing what that pressure was relative to the atmospheric pressure across the eye. Then Goldman, in his wizardry, created a 3.06 millimeter diameter applanation device to flatten the cornea. And when the cornea became flat, the pressure that it was applying was equal to the pressure inside the eye. So the transcorneal pressure difference was neutralized to show what the pressure was inside the eye. Now, let's take a step back. If I asked you what's the pressure inside the eye, you'd probably say something like 20 millimeters of mercury. Well, the truth is that it's not 20 millimeters of mercury. It's 20 millimeters mercury greater than the pressure outside the eye in the atmosphere. The absolute atmospheric pressure is 760 millimeters of mercury outside the eye at sea level. So the absolute pressure inside the eye is 20 millimeters of mercury higher than that. Now, please don't stop listening as I start to talk about this. I really do have a so what here. The gauge pressure is the pressure across the cornea. And this all creates a standard of comparison that's important. And as the atmospheric pressure changes, all the bodily pressures change in lockstep. And every FDA drug and device approval that I've ever seen uses the atmosphere as a reference point. So let's all transport ourselves to the Caribbean. And we're at sea level and we're enjoying this view over on the right. If you look at those top numbers, the atmospheric pressure in the Caribbean at sea level is going to be about 760 millimeters of mercury. The pressure inside the eye is, let's say, 20 millimeters of mercury higher than that. So it's 780 millimeters of mercury. The intracranial pressure behind the eye would be 12 millimeters of mercury higher than atmosphere. So 772 millimeters of mercury. So the relative pressures relative to atmosphere would be 0, 20 intraocular pressure, and 12 intracranial pressure. Now, let's say you go scuba diving. And it was during scuba diving that I had the idea that intraocular pressure alone wasn't the only thing that mattered in glaucoma. So if you're a scuba diver, you know that if you go down just 30 feet, 10 meters, you add 760 millimeters of pressure to your entire body. So the pressure outside your body is now 1,520 millimeters of mercury. The pressure inside your eye went up to 1,540 millimeters of mercury. And your intracranial pressure went up to 1,532 millimeters of mercury. But notice that the surrounding pressure stayed at 0 if you reference to there. The intraocular pressure stays at 20 and the intracranial pressure stays at 12. So there's no new pressure differentials created. And that's actually my family scuba diving there. And that's my son getting his scuba certification. And it was on a scuba dive where I thought, wait a second. If I go down just 30 feet and I add 760 millimeters of mercury pressure to my eye, how does it perfuse? How is it possible that you don't have the signs and symptoms of angle closure glaucoma? I would drill a hole in your eye today if your pressure was 60 millimeters of mercury, and we're talking about adding 760 millimeters of mercury. And so that got me thinking. So now what about the opposite? Let's say we go up to Denver, where the atmospheric pressure is much less. Now the absolute pressure outside the eye is 610 millimeters of mercury. The pressure inside the eye is down to 630 millimeters of mercury, and the intracranial pressure is 622. Well, we just lowered the absolute intraocular pressure 150 millimeters of mercury. But do people in Denver still get glaucoma? Yes, they do, despite the fact that they're at this elevation and despite the fact that there's very loose cannabis laws in Colorado. People in Denver still get glaucoma. So what does this mean? It's not the absolute pressure inside the eye that matters. It's pressure differentials that matter. So let's think about the pressures in the eye, okay? You've got the intraocular pressure, but think about the optic nerve as it exits the back of the eye. What's the first pressure it's exposed to? Intracranial pressure. It bathes the optic nerve all the way into the back of the eye and extends into the brain and into the spinal column. But then there's also the blood pressure, where the mean arterial pressure is 90 millimeters of mercury. There's the retroorbital pressure. That's the pressure in the fat surrounding the eye. That's about 4 millimeters of mercury. There's the transcorneal pressure difference, what we usually think of as IOP. And that's what we measure with Goldman applanation, eye care applanation, pneumotonometry, you name it. It's measuring the transcorneal pressure difference relative to the atmosphere in front of the eye. There's the translaminar pressure difference, which would be 8 millimeters of mercury. So that's across the lamina cribrosa, and that's the difference between the intraocular pressure and the intracranial pressure. And that's actually the pressure differential that I believe is the most important one in glaucoma. But you also have ocular perfusion pressure, which in this case would be 70 millimeters of mercury, because the mean arterial pressure is 90 millimeters of mercury and the intraocular pressure is 20 millimeters of mercury. So this can start to get confusing, and it's way more than just intraocular pressure. So I'll tell a little story. I was a first-year resident now 15 years ago at Duke. And in our one vacation that we had, my wife and I went scuba diving. And like I said, I was down 30 feet, and I thought, how could all this pressure get added to my eye and I would still be able to perfuse it, not have a bunch of pain, and see? And so instead of enjoying a Corona and my one vacation, this idea became kind of like, I became like a dog with a bone with this idea, and came to believe that it wasn't the absolute pressure inside the eye that matters. It's the pressure in the eye relative to the CSF pressure. And the best way we can measure that relative pressure is by doing measuring it relative to the atmosphere. So I came back from my residency. I talked to Rand Allingham, one of my professors at Duke, and I said, hey, Dr. Allingham, I think I figured out what glaucoma is. It's a disease of two pressures, a high intraocular pressure or a low intracranial pressure. He said, I think you're wrong, but go study it. So indeed, I went to the Mayo Clinic because they had a big electronic medical record. I worked with Doug Johnson, one of the great people in ophthalmology, glaucoma specialist. And we looked at over 50,000 lumbar punctures, spinal taps, that were performed over a 20-year period. And indeed, what we found was that patients that had glaucoma had a low intracranial pressure compared to patients that didn't have glaucoma. Now, I'll explain these theories here in a second. And further, and we published that in ophthalmology. Then further, we went and we looked at intracranial pressure in patients that had normal tension glaucoma, primary open angle glaucoma, controls, and ocular hypertension. The idea being simply this: if you have a normal eye pressure and a really low CSF pressure, you have a pressure differential across your lamina cribrosa. If you have a high eye pressure and a normal CSF pressure, then that would be primary open angle glaucoma, and you'd still have a pressure differential across the nerve. Reverse that, and you have a higher intracranial pressure than you have intraocular pressure, and that's papilledema, and we see that in pseudotumor. Now, what about ocular hypertension? Well, that'd be somebody that has a high eye pressure, but also has a high intracranial pressure. So the ocular hypertensive may be protected by an elevated intracranial pressure and has not developed glaucoma. So here's what we found. Indeed, patients that have glaucoma have a lower CSF pressure. People that have normal tension glaucoma have an even lower CSF pressure, and people that have ocular hypertension have an elevated and potentially protective CSF pressure because they're the ones that haven't developed glaucoma. So I come back from the Mayo Clinic with this data, and I am so excited, and Dr. Allingham is excited, and I'll never forget a phone call I got from Dr. Allingham that said, you know, I was kind of skeptical of this, but then I saw one of my glaucoma patients this week, and they had just had a lumbar shunt placed, and that's intended to lower CSF pressure, and their glaucoma fell off the table and got way worse. So we come back and we talk to the chairman at Duke, David Epstein. And if you got the privilege to know David Epstein, he was a brilliant mind, he was enthusiastic. And when he got really excited, he'd talk and there'd be a little bit of foam in the corner of his mouth because he was so excited. And the questions, they just started flying. Like, what happens to IOP with age? And I'm going to pause here for a second and ask you to answer this question in your own mind. What happens to IOP with age? Does it go up? Does it go down? Does it stay the same? Now just be true to yourself. Answer it in your own mind. And the answer is that IOP goes down as you get older. Now I asked this exact same question to a group of glaucoma specialists, and you know what? The room was split, a third, a third, a third. A third said it goes up, a third said it goes down, a third said that they didn't know and that it stayed the same. And how amazing is it that something as basic as what happens to IOP with age wasn't really known by a group of glaucoma specialists. And so this has been borne out in a number of different studies that intraocular pressure either stays the same or goes down with age. Then you would ask yourself the question, why does glaucoma increase in incidence as we get older if IOP stays the same or if IOP starts to go down? So that leads to the next question. What happens to intracranial pressure with age? Now we wouldn't expect, glaucoma specialists to know this, so we did a study on it. And this curve makes up 14,000 data points, 14,000 lumbar punctures from the Mayo Clinic. And if you look right at age 65, what happens to CSF pressure? It starts to go down rather precipitously. So what is that? So if we turned this curve upside down and said, oh, look, it looks like IOP is going up as you get older, we would say, of course, that's why older people get glaucoma. But that doesn't happen. In fact, what happens is the opposite. CSF pressure goes down. And so as CSF pressure goes down, the pressure differential across the optic nerve goes up. And this is one of the reasons why I think glaucoma is more common in older people, is because CSF pressure goes down. Well, that's what our study showed. What did the other study show? And that's similar. Intracranial pressure seems to go down with age across all ages. Very similar to what we saw in our study. Now, what else could affect CSF pressure? Well, there's a very fascinating study by Lou Pasquale out of Harvard that showed that as that increase in body mass index, BMI, as BMI goes up, what happens to intraocular pressure? It actually goes up a little bit, just a little. What happens to glaucoma risk? It goes down, especially in females. So think about that for a second. Being overweight increases your IOP, but decreases your risk of glaucoma. So what could be going on? Well, we published another study that looked at CSF pressure compared to BMI, and CSF pressure definitely goes up with increased BMI. And that makes sense with conditions like pseudotumor cerebri. We know that people that have pseudotumor with those elevated CSF pressures have a tendency to have higher BMI. So, and we're not the only folks to show this, that obesity is at least not a risk factor for glaucoma, even though IOP goes up, and it may actually be protective in some populations. Now, I've mentioned a couple of my heroes here, Rand Allingham on the left, David Epstein in the middle, and Doug Johnson on the right. I just want to pause for a second because all of them have passed away. And we published this first paper less than 10 years ago. And in the last 10 years, or about 10 years ago, all three of them aren't with us anymore. And I just say that as a reminder to myself and a reminder to you that our time here is short and we need to enjoy it. We need to be good spouses, good parents, good doctors, good partners, good colleagues, good leaders. We need to have fun, and we need to try and make our mark because our time here is so short. And I am so grateful for each one of these men and the role that they played in my life and in this project. So let's go to a couple other men that have been important in my life. That's me on the right. In the middle is my dad. And on the far left, if you don't know who he is, you must not spend much time learning about eyeballs, because that's Dick Lindstrom, and who I would say is the most famous ophthalmologist in the world, and probably the most influential. And I'll just tell a quick story. I did DMEC on my dad. He had Fuchs dystrophy. Maybe I'll have it someday, but I did DMEC on my dad. Dick Lindstrom was my mentor and taught me how to do that. And isn't that how the world's supposed to go? You get trained by a hero so that you can take care of your community and maybe even your dad with some special surgical technique. And so I remember in my fellowship, after we publish these papers, I get some time to present this story of CSF pressure in glaucoma to Dick Lindstrom, and I go in and I present it to him, and he says, "I think you're right. What are you gonna do about it?" And I'm like, "What do you mean, what am I gonna do about it? People are gonna think I'm smart and I'm gonna be famous." He's like, "Well, I actually like to use scientific discoveries to help people. Maybe turn it into a technology, maybe even turn it into a company that can help everybody around." And I said, "I don't have any good ideas." And he said, "That's okay. Opportunity favors the prepared mind." I said, "Okay." So fast forward a few years later, and I'm reading an article in the Wall Street Journal. And that's talking about how astronauts on the International Space Station are losing vision. And I remember thinking, I know what's going on. And it's a balance between intracranial pressure and intraocular pressure that's the issue. And so I wake up my wife to tell her how smart I am. And she says, "Let me tell you how smart you are for waking me up. That's how smart you really are." And so that night I emailed the highest ranking MD that I could find at NASA. And he, no kidding. And I said, "Hey, I'm John from South Dakota. I think I might know what's going on with these astronauts." And no kidding, he emailed me back. And so what's going on with these astronauts is that they've got a syndrome that includes optic disc edema, globe flattening, choroidal folds, and a hyperopic shift. Now, when you see optic edema and choroidal folds and a hyperopic shift, what does it make you think of? It kind of makes you think of hypotony. When a patient has, too low of eye pressure, you see all of those things. Well, what's too low of eye pressure? And why do you see those things if the eye pressure is low? Well, probably because the eye pressure is lower than the CSF pressure. What else does that kind of sound like? It kind of sounds like pseudotumor cerebri or idiopathic intracranial hypertension, right? Where you see optic disc edema. What do those things share? Well, both of them are where the CSF pressure is higher than the IOP. And instead of cupping like the optic nerve does in glaucoma, it bulges forward because now the pressure differential has been reversed. And this is a MRI of an astronaut after they return from space, and you can see how that posterior globe is flattened. But even more impressively, what you can see is behind the globe, there's a swelling of the CSF space, and it's expanded. So I wrote a paper along with Dao-Yi Yu and Bill Morgan that hypothesized that it's the translaminar pressure gradient that causes this syndrome in space. And perhaps it's likely a bit more complicated than that, but the idea is simply this. On Earth, as you're sitting there listening to this lecture, your cerebral spinal fluid is getting pulled down by gravity into your caudal spinal column. And your CSF pressure at eye level is lower because of gravity. Now, if I turned you exactly upside down, all those fluids would rush to your head and your CSF pressure at eye level would get higher. Well, in space, there's no gravity. And so in the setting of no gravity, your CSF would distribute more evenly than it would with gravity on Earth. And now your CSF pressure at eye level is going to be higher. And if that's higher than intraocular pressure over time, you could develop papilledema. So we published this paper, and I actually got invited to work with NASA and the NSBRI for the Vision for Mars team. And so it's been so incredibly fun, and I've gotten to know a couple astronauts, and I'm kind of like a kid in a candy store. And seriously, I get to actually help NASA try and figure out this problem. And it's been really one of the fun things that I've gotten to do off and on throughout my career. But I still don't have an idea per Dr. Lindstrom of what are you gonna do? And that's where my partner Vance comes into the equation. This is us on the plains of South Dakota, and we're ping-ponging ideas back and forth. And he says, well, maybe you could just put a helmet on the astronauts and pressurize the helmet, and that would raise their eye pressure to balance out the CSF pressure. I said, well, but Vance, that'll raise the eye pressure, but it'll also raise the CSF pressure because the brain's inside the helmet too. And he says, oh, good point, buddy. And then I say, but what about a pair of goggles where we would put the goggles over the eye, add positive pressure in the goggles, push on the eye, and raise the intraocular pressure? And so with that, an idea and a company was born, and we're going to head that way in a moment. But take a look at this histologic image of the back of the eye. You got the retina, you got the lamina cribrosa, you got the optic nerve, you got this intraocular space right here, and you've got the intracranial space in that light green. And just look at this image for a second. We spend all of our time talking about intraocular pressure when more of the optic nerve is bathed by intracranial pressure than intraocular pressure, and it's only 500 microns or so from the surface of the optic nerve to the intracranial pressure. So 5 or 6 pieces of paper thick. That intracranial pressure has to affect the optic nerve. And indeed, we know it does, because in diseases of elevated intracranial pressure, that lamina cribrosa and that optic nerve head bows forward. And in case of elevated intraocular pressure, it bows backwards like glaucoma. So the normal is a situation where intraocular pressure is a little bit higher than intracranial pressure. Glaucoma, where there's cupping, would be where the intraocular pressure is quite a bit higher than the intracranial pressure, or vice versa, the intracranial pressure is lower than the intraocular pressure. And forgive me, there's a typo on that last one. Papilledema is where the intraocular pressure is lower than intracranial pressure, or how we usually think about it is intracranial pressure is high. Okay, so yes, we measure the pressure differential across the cornea, and that's what we're measuring with Goldman applanation. But what it is, it's a surrogate for the intraocular pressure, which is the pressure inside the eye relative to the atmospheric pressure. But we don't really care what the transcorneal pressure difference is. We care about the translaminar pressure difference and the difference between intraocular pressure and intracranial pressure as it crosses the optic nerve. So let's get even more philosophical. What kind of disease is glaucoma? Is it a mechanical disease? Is it a vascular disease? Is it a metabolic disease? Is it what most glaucoma specialists like to say, is that it's multifactorial and there's a whole bunch of things that can cause it? That generally doesn't turn out to be the case. It's usually the simplest answer that's true, but it could be. So the mechanical hypothesis is this, that it's the stress that occurs across the ganglion cell as it exits the lamina cribrosa that causes the disease, the stress and strains on the optic nerve. The vascular hypothesis says that it's low blood pressure or low blood perfusion that causes the optic nerve ganglion cells to die. Now, I do think, and there is data out there to support that, decreased blood flow can cause damage to retinal ganglion cells. But the other thing that decreased blood flow, or more specifically decreased blood pressure, causes is a decrease in CSF pressure. So when you see those little old ladies that are getting worse than their glaucoma and their pressure is 15 and their blood pressure is 80/40, I bet a donut that those patients have low CSF pressure too. And then there's metabolic. And what does that mean? That really means axonal transport. And that's the theory that I subscribe to most vigorously. Because if you have an elevated intraocular pressure or a low intracranial pressure, you create a pressure differential across the optic nerve head, and axonal transport slows or stops at the level of the lamina cribrosa. And this was demonstrated in a classic paper by Doug Anderson and Harry Quigley from 1978. What that study showed was that as they raised IOP in monkeys, axonal transport stopped at the level of the lamina cribrosa. Now, they didn't look at CSF pressure. But what they did also show is that if you raise the eye pressure in these monkeys, you would stop axonal transport at the level of the lamina cribrosa. And if you lowered it for 4 hours, you would have resumption of axonal transport, and you couldn't detect that the axonal transport had stopped in the first place. Now think about that for a moment and its implications, because perhaps if we could get the eye pressure low enough, long enough, and normalize axonal transport and allow it to flow, perhaps we'd be able to prevent ganglion cells from dying because they got the metabolic needs that were necessary and the metabolic toxins were removed. So what are some other things that we do know? We know that lowering intraocular pressure, even in ocular hypertensives, helps. And only, and if you lowered intraocular pressure, about half of the patients go on to develop glaucoma that would have otherwise. So that's our usual take home from the OATS study. If you treat people, you will decrease their risk of developing glaucoma by 50%. That's true. But in a 5-year period, only 10% of people developed glaucoma. 90% of people didn't develop glaucoma. Why not? Well, I would think that it's likely because of elevated CSF pressure. So let's talk about it the other direction. In the United States, what percentage of glaucoma is normal tension glaucoma? About 30%, somewhere between 20 and 50%. 40 to 70% is mild to moderate glaucoma. We've got a ton of great answers for that. We've got 5 different categories of medications. We've got more MIGs than you can shake a stick at. We've got SLT, which is fabulous. We've got lots of good answers for mild to moderate glaucoma. 8 to 10% of people have severe glaucoma. We don't have good answers for that. We don't have good answers for normal tension glaucoma because most drops don't work well in normal tension glaucoma. MIGS doesn't work that well in normal tension glaucoma. SLT doesn't work that well in normal tension glaucoma. The only things that really do are transconjunctival surgeries like Zen tube shunts and trabeculectomies, but those all come with significant morbidity. And so that's the real risk that still exists in glaucoma. So is there other evidence to support this besides what we've done? Well, our original paper has been now cited well over 400 times in the literature. And this is one of the great studies that was done by Bob Weinreb, Joost Jonas, Ningli Wang, et cetera, where they showed that if you lowered CSF pressure in monkeys, you saw retinal nerve fiber thinning without even changing the IOP. And other groups have looked both prospectively and retrospectively at CSF pressure in glaucoma, and they found essentially the same things that we did, and that the translaminar pressure difference goes up. You can see in patients that have normal pressure glaucoma that their optic nerve sheaths have a smaller diameter, which would indicate a lower CSF pressure. Now, there is one paper out there in ophthalmology, but it only had 13 patients in it, that showed that their conclusion was that there wasn't a difference in CSF pressure, although there actually was a little bit of a difference in CSF pressure. So how could we use this information about CSF pressure to help our patients? Well, if we could measure it non-invasively, we could use it to set a target eye pressure. If their CSF pressure was 9 and we knew that they could tolerate a pressure differential of 4 on average, we would set an IOP target of 13. Or this could be an entirely new area to target drugs that could elevate CSF pressure. But I'm not smart enough to think of any of that stuff. So I thought of a pair of goggles that could actually lower the intraocular pressure. So let's go back to this diagram. And we're going to assume that the pressure inside the eye is 22 millimeters higher than atmospheric pressure. So they had an IOP of 22 and they have an intracranial pressure of 9. That leads to a translaminar pressure difference of 13 millimeters of mercury. Okay. If we put a pair of goggles over the eye and we draw a vacuum of 10 millimeters of mercury in that goggle, what we just did in essence is decrease the amount of atmospheric pressure that is applied to the eye by 10 millimeters of mercury. So there's 10 millimeters of mercury less force placed on the eye. So the pressure inside the eye should go down 10 millimeters of mercury from 22 to 12. Now it turns out that that isn't quite what happens. It probably goes down, instead of 10, it probably goes down 6, because it increases blood flow to the back of the eye and there's a new pressure volume relationship that's established. But regardless, the principle remains the same, and that pressure differential across the optic nerve head that was 13 goes down to 3 millimeters of mercury. And so our idea was to use a pair of goggles to either add pressure to the eye if we want to increase it and treat conditions of elevated CSF pressure, or put negative pressure in the goggles and decrease the intraocular pressure to treat glaucoma. And the beauty of it is that it's based on physics and it's titratable. It's not based on the biological responses of the eye as much. And here's one of those papers that we're studying. And this weekend, for the first time ever, we're going to present our pivotal data at the American Glaucoma Society. But this was from an earlier paper that we published, where we put the goggles on one eye and compared it to a control eye. Both of them had a baseline pressure at 16. And you can see in the blue, when we dialed in a 25% pressure reduction, we saw a decrease down to 13.5 millimeters of mercury. When we dialed in 50% reduction, it went down to 11.5. And when we dialed in a 75% reduction, it went all the way down to 10 millimeters of mercury. Now, it is difficult to safely and consistently take a pressure from 16 millimeters of mercury down to 10 millimeters of mercury. And the studies that we've done in our pivotal trial are all in addition to the medications that they're already on. And I'm excited that that'll be public. And I wish that I was giving this presentation next week so I'd be able to share that data with you. So let's go back to the problems that we started with in the first place. Just answer them in reverse order. Why does IOP matter? Well, IOP, the transcorneal pressure difference relative to atmospheric pressure, is a surrogate for the translaminar pressure difference, the difference between intraocular pressure and intracranial pressure. So what causes that cupping and visual field loss that we see in glaucoma then? Well, the cupping occurs because the intraocular pressure is higher than the intracranial pressure, and those uneven forces lead to a cupping and a backwards bowing of the lamina cribrosa. What causes visual field loss? Well, visual field loss is caused by ganglion cell death. Why did the ganglion cells die? I believe that that happened because axonal transport was slowed or stopped at the level of the lamina cribrosa. The ganglion cells didn't get the nutrition they needed, nor were the waste removed properly, and they underwent apoptosis. And so, as I told you in the beginning, I was a math teacher, and so what is glaucoma? Well, I would say that glaucoma is the intraocular pressure minus the intracranial pressure divided by the lamina cribrosa thickness, or the biomechanics of the lamina cribrosa. That's the translaminar pressure gradient. You multiply that by time, and you get glaucoma. So, perhaps there's other things involved, but I actually do believe that this is the primary driver of glaucomatous disease. So I'm going to end with asking you the same question that Dick Lindstrom asked me. So what? So what are you going to do about it? We need all of us. And as clinicians, we've got all of this unique insight into our patients every day. So let's use our minds, let's use them together, let's collaborate, let's understand these diseases. Glaucoma is the second leading cause of blindness in the world. Let's understand them better, let's think about them differently, let's think about them better, and let's come up with some solutions for those patients who put their trust in us. Thank you guys so much for listening, and I'm eager to take any questions.
Wow, this is cutting edge stuff. I mean, I was just thinking about when I was in optometry school and how much we learned about glaucoma and the OAT study and everything, and how, I mean, it's really mostly about intraocular pressure. I guess intracranial pressure was not really discussed in as much detail that you went over. And I could tell you're a math teacher because you've made all of these kind of math type of things really easy to understand. So thanks so much. We do have some questions. This is a great question from Dr. Reisman. Why do we encourage glaucoma patients not to do inversion exercises like yoga or things like weightlifting or trumpet blowing?
Yeah, I think that we're wrong in advising people to not do those things. To my knowledge, there's never been a study that any of those led to worsening of glaucoma, only that it led to an elevation in intraocular pressure. But if that elevation in intraocular pressure was matched by an elevation in intracranial pressure, it shouldn't matter. Just like you go on an airplane, when the pressure inside your eyeball goes down, so does all the other pressures in your body.
Right. It's like it's just a ratio or, relationship of what's going on in that environment. Like you said, in Denver, it's not like less people have glaucoma there because the altitude is higher and the atmospheric pressure is lower. So yeah, that's really interesting. Dr. Ung wants to know, why are we not looking at increasing CSF pressure more in very progressive glaucoma?
Yeah, really good question. So why don't we do spinal taps on patients? Probably because they're spinal taps. Yes. One, we don't do those in the first place, so it's not like it's a skill that we have. So we'd have to refer it. And number two, it's not a pleasant procedure to go through, and it does have some morbidity associated with it. That's why I really wish that we had a non-invasive way to measure CSF pressure. We're actually trying to develop that as part of our goggles with some imaging. And other people have tried, but we haven't gotten something that has the fidelity that we need, that's probably about 2 millimeters of mercury. NASA's also very interested in this. So the short answer is, the reason we don't do it is because we don't have an easy way to do it, and we need something that's non-invasive.
Yes, I agree with that. Dr. Dreen wants you to know that this is by far the best glaucoma CE she has ever attended.
Was it Dr. Dreen?
Dreen.
Yeah, tell Dr. Green she is by far the best attendee I've ever had at any of my glaucoma sessions. Thank you. I love compliments.
Aw. Another question. Can we treat glaucoma with inversion boots? IOP increases at night while sleeping. Does the increase in CSP counteract this?
Great question. We know IOP goes up at night. CSF pressure probably goes up a little bit too, but not as much as intraocular pressure. So we think, I won't say that we know this for sure, we think that nighttime is a vulnerable period for glaucoma, because intraocular pressure goes up, blood pressure goes down, and we think that those elevations disrupt axonal transport and lead to damage at nighttime. So the question is a good one. Some people would say, hey, you should sleep with your head up at night. Why? Because your eye pressure won't go up as much. But your CSF pressure won't go up as much either. In fact, it's a column of fluid. So you could make the exact opposite argument. Lay upside down a little bit, because your intraocular pressure will go up, but your CSF pressure should go up more.
Yeah.
That really betrays our lack of understanding of this disease. Very smart people could disagree exactly the opposite on what you should do. And that just shows we don't know what we're talking about.
Well, I think that the very first slide you had was, what is glaucoma, or what causes glaucoma? What is it? We don't know. And I think that the more research we're doing, all the studies that you've been involved with, and just advancing the profession with some of your mentors, this is really what is going to change the industry and help us get some of these answers. So this is outstanding work that you're doing.
I sure hope so.
Question from Dr. Gold. Does the pressure differential also impede the flow of blood into the eye?
It does. It absolutely does. And so if intraocular pressure goes up, blood flow goes down. If intraocular pressure goes down, blood flow goes up. We don't know specifically how CSF pressure affects blood flow at the optic nerve yet. That is an area for research, and it's an important one, but that isn't well known, or at least it's not well known by me.
Makes sense. Dr. Haidatov wants to know, have the goggles been approved as a treatment for glaucoma, and how long would they have to be worn throughout the day for it to effectively decrease the pressure?
Great question. They're not FDA approved yet. We've gone through a number of trials. We're working with the FDA. We're hopeful that we can get them approved. There's real work that has to be done to, prove things with the FDA. How long would patients have to wear it to have an impact on disease? Is the question. My knee jerk is 4 hours. And that comes a little bit from that Quigley study that I mentioned and some others, where if you normalize the pressure for 4 hours, you can see a clearing of the toxic metabolites that are up. Mm-hmm. But we don't know that for sure.
Wow.
What we do know is lowering IOP is good. Yep. And we would expect that most patients would be wearing this at night, kind of like a CPAP, because their eye pressure goes up at night, their blood pressure goes down at night, and we think that's a vulnerable period. So that's how it would likely be used. I could envision patients that have one eye and real bad glaucoma wearing it longer than that.
Yep, absolutely. Great question from Dr. Stralka. Does Diamox also lower the cerebral spinal fluid pressure?
Yes, Diamox does lower CSF pressure in a very similar mechanism to how it lowers IOP, because they're both made by a structure it's the choroid plexus in the CSF, very similar to the ciliary body. And so one of the questions we wonder is, does Diamox treat us more than it treats a patient if it doesn't change the translaminar pressure difference? Now, what probably actually happens is that Diamox works preferentially on whichever pressure is higher. So if your IOP is really high, it would lower IOP a lot and CSF a little, or vice versa. If CSF is really high, it'll lower that a lot and IOP a little.
Interesting. Okay, great. Thanks for that. Great question from Dr. Mehta. Would elevated blood pressure also be protective for the optic nerve in spite of elevated IOP?
I don't know is the short answer, but that never stops me from really trying to answer a question, even if I don't know. The literature out there shows that low blood pressure is a risk factor for glaucoma, but high blood pressure is not protective. And that's probably because in glaucoma patients, autoregulation is lost. And it's, I think it's, likely not that there's an issue of decreased blood flow there as much as there's an issue of what is the CSF pressure and what's happened to the ganglion cells. Because vascular diseases usually happen quick: strokes, heart attacks, ischemic events. Glaucoma happens over years to decades. So it seems to me like it's more a disease of the axonal transport and metabolism than it is a vascular occlusive event. Think of the NAION. That happens like that overnight.
Right.
And you wipe out half your visual field.
Yep.
Glaucoma doesn't quite behave that way.
Oh, that's interesting. A few questions on keratoconus patients. Would they be more at risk for glaucoma because of a weaker lamina, or are there any studies showing that keratoconus patients develop glaucoma more?
I was just looking at an AOS thesis on this yesterday, and it turns out that keratoconic patients are not at a higher risk for glaucoma. After they have a transplant, they are, because of the steroids and the biomechanics of the transplant. Keratoconus patients are not at higher risk. Now, what we don't know is, do keratoconus patients have a more susceptible lamina cribrosa? I'm not aware that any data has shown that their lamina is more fragile.
Yes. Okay. Excellent. And I know that you have to hop off very soon, but we do have a few more questions.
Let's get after them.
You just tell me when you need to leave, and we'll shut it down.
3 minutes.
Okay. Dr. Stockwell wants to know, if the goggles are approved for glaucoma, will they also be used to treat papilledema?
The initial set of goggles would, if they're approved, God willing and FDA willing, would be for treating lowering IOP for glaucoma patients. We have not put a pair of positive pressure goggles through any sort of clinical trials yet.
Okay. Dr. Warren wants to know, how common is hyperopic shift in astronauts?
Fairly common. It's at 50% or higher on long-term space flight. We never saw it on short-term space flight, but it's 50% or higher on long-term space flight.
Okay. Dr. Ta wants to know, when patients wear the goggles at night, does REM sleep have any effect on IOP?
I should know the answer of whether or not REM sleep has effect on IOP. I don't know the answer to that, other than I think in the back of my mind that it is true that when the muscles are contracting, that puts a little external force on the eye and IOP goes up. But I don't think that that's the reason why IOP goes up at night.
Excellent. Okay, last question from Dr. Boudoin. Do you think that pressurized goggles could serve as the sole treatment for glaucoma?
I think it would be a reach to say that. And I also think that it would be a reach to say that patients would rather put on a pair of goggles at night than take a prostaglandin. I think that an SLT or a prostaglandin is a great first-line therapy for glaucoma. Now, if you're pharma averse, can't tolerate it, maybe you're a little bit more holistic and you don't want drugs or something, then maybe that would be the case. But we're going to try and do the science to see if we can lower pressure for 6 hours at night and lower it really well right to where we want it to be. Can over time we demonstrate that that is going to slow progression of the disease, and what understandings will that unlock for us? So I think the short answer is probably not, but I wouldn't say zero possibility.
Yeah, like with anything, right? We have lots of tools in our toolbox to treat a certain condition. And a lot of times one patient may not respond to one thing and they do well in the other, or they need a combination. And just, I think that'll probably be, if I had to
We all want
predict.
more tools in our toolkit, especially ones that are safe.
Absolutely. Well, there's a million comments on how interesting this lecture was and how it's so great. It's not the same old glaucoma material that they hear over and over again. And just thanking you for such an amazing lecture and presentation. So thank you, Dr. Berdahl, for spending your evening with us and educating the WooU audience. And we look forward to having you back someday.